much, and a very, very good morning to all of you. Today, it's actually a pleasure to talk on a topic that's very close to my heart. I want to thank KDSG and the sponsor for this particular session. And before I even start, I just want to say that as we are marking a decade in the conferencing at KDSG, I'm also marking another decade. My son turned 10 yesterday while I am here. So I dedicate this talk to him actually. So today it's double celebration for me. So without wasting then more time, this is a sponsored talk, and this is going to be the outline of this presentation. We'll go through the introduction very briefly, look at the clinical presentation, diagnostic criteria, role of AMH, because that's where the topic is. AMH stands for anti-Mullerian hormone. And then we look a bit, touch on the treatment, and then conclude. So as an introduction then, what we know is that PCOS, or polycystic ovarian syndrome, is actually the most common chronic endocrine condition that affects women of reproductive age. And it actually goes all the way from menarche to menopause. And as you can see, it is associated with multiple conditions, basically, within the condition, the syndrome itself, where you have the psychological element being affected, you have got your endocrine and metabolic disturbances like dysglycemia, impaired glucose tolerance, dyslipidemia, cardiovascular disease risk, and on the other hand, you have got a whole load of reproductive concerns, including hyperandrogenism, polycystic ovaries, the morphology itself, irregular menses, and also associations with other conditions like fertility or infertility. About 8 to 13% of women of reproductive age are affected by polycystic ovarian syndrome. And about 50% of women who have PCOS tend to have fertility issues or infertility. And what's interesting is about 50% of these women, by the time they turn 40, will have type 2 diabetes. And what is very sad is that more than 66% do not know that they have PCOS. They remain undiagnosed. So this is a call to action to all of us. And so it affects about 1 in 10 women if you look at it figuratively. And just to look at the prevalence and the burden of PCOS across the globe, this is an analysis that looked at the prevalence across the globe from the year 1990 comparing to the year 2021. So as you can see, the blue is in the figures in 1990, whereas the red is now 2021. And across the globe, across all the regions, including Africa, I don't know how much data they got from there, but they did get some data, and the prevalence is increasing. And we can see that that is also a concern, including the incidence. And when you look at the regions, the 5 regions, then we can see the prevalence, incidence, and disability-adjusted life years are all on the rise in every region of the world. So when we look at the pathophysiology of polycystic ovarian syndrome, nobody actually knows why it happens exactly, but there is actually a postulation of all these factors which contribute, which is the environmental toxins, associations with genetic predisposition, and their genomic marking that is being done to show which genes are associated. There is, like every other chronic disease, the whole aspect of the gut microbiome being associated, and so gut dysbiosis is thought to be a marker in the pathogenesis, and also lifestyle disturbances like diet and lifestyle conditions with the changing in the diets that we currently have. And all these will lead to 3 major issues, which is hormonal imbalance, which means that you have got a disturbance in your hypothalamo-pituitary gonadal axis, whereby you get a reduced production of FSH, you get an increased production, or rather an imbalance between the LH and FSH. And they may actually be within normal ranges, but the ratio is altered. And so that's the hormonal aspect. And then you have hyperandrogenism as the key in the pathogenesis, where you've got decreased sex hormone binding globulin and increased testosterone levels. And on the other hand, a big key marker is insulin resistance. And especially as we shall see in the obese phenotype, you have more of this element contributing to the pathophysiology, where you have increased insulin levels, and also that contributes to your dysglycemia, impaired glucose tolerance, and type 2 diabetes risk. And all that then contribute to giving you your polycystic ovarian syndrome, which goes with clinical features with hirsutism, acne, reproductive features like oligoamenorrhea, irregular menstrual cycles, and fertility concerns, and metabolic features as mentioned. And this is just saying that this is actually a vicious cycle of hyperandrogenism, insulin resistance, and in addition, you have the element of chronic inflammation, fibrosis, and oxidative stress, which contribute further to the pathogenesis. And here I just want to, at this point, bring in the element of anti-Mullerian hormone. So anti-Mullerian hormone is actually a hormone that's produced in the fetus, both in male and females. And in males, the role is to suppress your Mullerian hormone so that you get Mullerian dysgenesis, so that you develop male sexual characteristics and not female. In women, why it exists is not 100% clear, but there is a role in regulation of your FSH, okay? And in men, by puberty, it goes off, but in females, there is a gradual decline over the years. So AMH is produced by what you call as the pre-antral follicles or small antral follicles, which are not the ovulatory follicles, which are not the primordial and the developmental, like the dominant follicles. So in the earlier phases of the ovulatory cycle, by the granulosa cells in the ovaries. And so what happens is when you have an increased AMH, it actually is a marker of your antral follicle count. And this is important as we shall discuss the where its role comes in now when diagnosing PCOS or PCOM. Okay, and the rest we have discussed. So what it does is it actually has an inhibitory effect on FSH on the ovary, and basically that also contributes further to your hyperandrogenism. So when you look at the pathophysiological variation, and this is important because you might see lean PCOS. PCOS is not only associated with overweight and obesity. You could actually have lean PCOS. And this is what the difference is when you look at the pathophysiology. In the lean PCOS, the main trigger is androgen, like hyperandrogenism, whereas in the obese PCOS, the main trigger is insulin resistance. And that's why you can then see the different phenotypes ranging all in between this spectrum. And so they are, based on that, then 4 basic phenotypes of polycystic ovarian syndrome. The one that we see most commonly is the classic PCOS. It's considered to be the most severe form of PCOS, where you have got all hyperandrogenism, oligoamenorrhea, and when you do an ultrasound, you find polycystic ovarian morphology. Now, there's a difference between PCOS and PCOM, and that is the difference where AMH comes in. So PCOM is just a polycystic ovarian morphology on an ultrasound, and I'll explain to you what that is. So the second type is now known as PCOS phenotype B, which is the hyperandrogenic anovulatory PCOS. Yes, you've got hyperandrogenism. Yes, you have got oligoamenorrhea, but when you do an ultrasound, there is no ovarian morphology of polycystic ovaries. Phenotype C is ovulatory, where you have got hyperandrogenism, and you do not have oligoanovulation, but when you do your ultrasound, you get PCO morphology. Whereas if you have the phenotype D, you have got mainly oligoamenorrhea and polycystic ovarian morphology. Okay, so your patient could be into any one of these phenotypes. And why these 3 characteristics? Because these are the Rotterdam criteria that are used for diagnosis of PCOS. You need at least 2, and we'll look a bit more into that. So PCOS is not 3 months, 6 months, 9 months, 12 months. It's a lifelong condition that needs support and treatment and has lifelong consequences thereby. Whereby, like I said, the impact on the psychological health, impact on metabolic health, increased risk of certain types of cancers, increased reproductive concerns, and others like cardiovascular mortality as well, effects on the liver causing not only reduction in your sex hormone binding globulin, but also an increased risk of MASL D, that is metabolic associated steatotic liver disease, increased risk of obstructive sleep apnea and lung dysfunction as well. So it has lifelong consequences. So to summarize the clinical manifestations, we can divide them into reproductive, metabolic, and psychological. As I have talked about, there is an impact on quality of life, there is an impact on eating disorders, there is an impact on self-esteem, especially for younger girls, seeking for reproduction and to have productive lives. So when you look at the impact across the lifespan, then this is what I'm talking about, is that in the reproductive years, in the younger years, your bigger issue is reproductive concerns most of the times, and body image, self-esteem, stuff like that, where you're looking at menstrual disorders, hirsutism, contraception, sexual health, and fertility. As you move on the spectrum, you have more complications like pregnancy-related complications, quality of life, and cardiometabolic dysfunction, and increased risk of cancers as well. And so you will see that this female actually goes through multi-dimensional care, including dermatology from pediatrics. It starts from adolescent care, and I'm glad we had the talk before me. Then dermatology, gynae, endo, diabetology, cardiology. So they end up seeing a lot of specialists. So it's quite an impactful condition. And so how do you diagnose PCOS? So I mentioned the Rotterdam criteria. But this comes now from the 2023 guidelines, whereby, and I really liked this, it makes my life easy at least, and I believe it will for all of us, to use a stepwise approach towards the Rotterdam criteria. What does that mean? When the patient comes, you take a good clinical history, okay? And the history you're looking at is, does this patient have menstrual irregularity? Do they have oligomenorrhea? Do they have amenorrhea, okay? So that's one, and then secondly, you look at features of hyperandrogenism. So you're looking at hirsutism, acne, and male pattern balding, okay? Now, if your patients have these two characteristics, there's only one more thing you need to do, is to rule out other diagnoses. So you need to do basic tests like at least a TSH, do at least a cortisol production evaluation like an overnight dexamethasone suppression test. Just give 1 milligram of dexa at 11 p.m. and get a cortisol in the morning, and it should be suppressed. And if it is not, then you start doing other tests. But you can do other tests to evaluate hypercortisolism. Again, depending on the clinical features, if the hirsutism is very fast or the hyperandrogenic features are within a very short span, look for adrenal tumors. So depending on what else you're having, you exclude the causes. Check a prolactin level, check FSH and LH to rule out secondary causes of amenorrhea. And then you say, okay, you don't need an ultrasound, by the way, this time. You don't even need tests to confirm hyperandrogenism. Already you have got your diagnosis of PCOS. So at this point, you have diagnosed the patient, okay? Now move to the step 2. So the patient has got no clinical hyperandrogenism. The patient has oligoamenorrhea, but no hyperandrogenism. Clinically, there's no hirsutism and all that. What will you do at this point? You will check for biochemical hyperandrogenism. You will still have ruled out your other causes of the condition like hyperandrogenism, as we mentioned already. And then you'll take your testosterone, DHEAS, and androstenedione as applicable, okay, wherever you get access to them. Both free and total testosterone are recommended. And then if a patient, and so that gives you your diagnosis. So again, at this stage, you really don't need to do an ultrasound. You don't need to do an ultrasound, okay? If you've got your clinical or biochemical hyperandrogenism and oligoanovulation. Now move to step 3. If you only have irregular cycles or you only have hyperandrogenism, okay? So what do we do in this case? In adolescence, you should not do ultrasounds. Up to the age of 19, it is not recommended unless you're looking for other things, because you could get a false positive because of the way their ovaries are developing, right? So if you have an adult, then at that stage, which I mean like you have either only one of them, then you will do an ultrasound to look for polycystic ovarian morphology. And this is where AMH comes in now. And that's what we'll look at moving forward. So this is your modified Ferryman-Galloway score. It's available freely on the internet. In your clinics, in primary care, endocrine care, gynae care, have these charts available. Just print them out and keep them there. You show your patients this chart of the MFG scoring and tell them where do you fit. At that time, remember, your patient could have come in directly from the salon, having shaved and done everything and removed all their hair. So that's not what you'll be following. Ask them what their hair is like before they have done the epilation or shaving, right? And then this is the Ludwig score. It's not the most sensitive, but it can guide you on male pattern balding in females. Now, these are just some biomarkers that we have available when you are evaluating for polycystic ovarian syndrome, but we will not use all of them, okay? But if you look at the biomarkers, if you look at this part, the reproductive biomarkers that I've talked about, basically it's just summarizing all the tests that can be used for polycystic ovarian syndrome. You have the DHEA, prolactin, sex hormone binding globulin, testosterone, AMH. And you can see the increase or reduction in those levels. You have your metabolic biomarkers, the dyslipidemia evaluation with lipid profile, HbA1c, fasting, glucose, blood pressure assessment, and other biomarkers which we will not always use in all patients. Many of them are even for research purposes. So moving on then is your ultrasound. So if you do an ultrasound, the best ultrasound to do is anyone? Transvaginal ultrasound, TVUS. And our gynaes are experts at that. We have 1 or 2 gynaes here, I'm glad. So that's what they do. So the transvaginal ultrasound is a technical scan, and it's a bit impractical when you look at patients like who are virgins or young girls, young adults. It's not the most practical, and it requires a lot of expertise and technicality to be able to assess. It's not always the most affordable and accessible test, but if the patient can do that, that is the best. Now here again, things have changed a bit. We have better and higher resolution ultrasounds, and where available, then this criteria applies. So previously we used to talk about 12 follicles and all. Now we are talking about 20 follicles. These are the antral follicles in the ovary. More than or equal to 20 per ovary is already diagnostic of the polycystic ovarian morphology, okay? Or an ovarian volume of more than 10 mLs, or if you do a transverse section of one transection, then 10 even is enough to diagnose, but actually looking at 20, so you just have to remember 20, 10, 10. Okay? And it is these antral follicles that are producing AMH. So that is why they correlate well with the ultrasound when you do your AMH level. So it's these primordial follicles, small preantral follicles, and the large preantral and the small antral. These are the ones that mainly produce AMH, and that's why they are predictive of your antral follicular count. Okay? The larger ones do not have that much production of AMH, if any. Okay? So then here, that's where the role of AMH comes in. And we've seen, like in gynecology practice, where they have easy access to ultrasounds themselves, they do ultrasounds, and they have the expertise. What would they do? They would usually go for doing the tests, follow the steps, and ultrasound is part of their care. For them, it's relatively simpler to do. But for us, in primary care and in the endocrine practice, to get quicker results where available, we need a better method or a faster method than subjecting everyone to the ultrasound. So remember, ultrasound is not for all the patients. It's only as and when indicated in the step 3, right? So in that case, then, there's this study, which is known as the Aphrodite study, which is quite an interesting study, actually, which looked at the cutoff value for this AMH to say that this is predictive of polycystic ovarian morphology, equivalent to what a transvaginal ultrasound will give you. So they had about 1,000. It's the largest study to date looking at this particular phenomenon. And they actually looked at, it is a case control retrospective, but they looked at half of their females actually had PCOS by any of the Rotterdam criteria, regardless of the phenotype. So they included different phenotypes, although one of their objective was to check the classical versus the non-classical, but they actually found that, they had that as their cases, and their controls were women who did not have PCOS by definition of the Rotterdam criteria. And they subjected these women to go through they took the AMH levels, and all of them had done a TVUS for the controls for any reason before, but not for PCOS, and for the cases who had done it for PCOS, okay? And what did they find? That there was a strong correlation of the anti-Mullerian hormone and antral follicular count based on the ultrasound that was done, the transvaginal ultrasound. Okay, and there's a linear relationship. And a cutoff of 3.2 nanograms per ml was proposed for the diagnosis of polycystic ovarian morphology. Again, I'm specifying that because this is not for PCOS cutoff, okay? They were looking for the morphology cutoff. And what they found is, again, across the ages, this could be useful at the cutoff of 3.2 nanogram per ml. and there was a similar performance in all the PCOS phenotypes. So you can use it for all phenotypes, but I must say that the ones where there was no polycystic ovarian morphology, the levels were a bit lower, but not statistically significant, but basically that is the subtype B, I think, yeah? And in that one now is, but still there was a significant association with the correlation, but that is if you have the morphology, right? So when you put it all together from multiple other studies, they do say that all studies are suggesting that actually AMH can diagnose polycystic ovarian morphology and can replace ultrasound in this particular place in the diagnostic algorithm. Okay, so that's what we are saying. We can use AMH of 3.2, that is the cutoff, measured by a standardized assay. Remember, you need to use standardized assays to measure these AMH levels to diagnose what? PCOM, polycystic ovarian morphology. How about polycystic ovarian syndrome? So for PCOS, now there are other studies which looked at the diagnosis in PCOS, polycystic ovarian syndrome. And some of these studies did show a benefit of doing AMH to the, in patients with PCOS, albeit with the higher cutoff. So the cutoff value that has been suggested by many studies is a value of 4.8. That's from this meta-analysis. However, a recent study done in 2024 actually suggested an even higher cutoff of 5.4 nanogram per ml if you are looking at PCOS, not at PCOM. So this is true, but not all the studies have shown that. And I'll tell you, there's a study published in February 2025 actually, which is again counteracting this particular meta-analysis which I projected. So this meta-analysis actually suggested that not all, like the criteria for diagnosis should only be for PCOM and not for PCOS. But the 2025 study, interestingly, again is showing that it can be used for PCOS. But at the moment, the guidelines recommend we restrict it to the diagnosis of polycystic ovarian, like at the level of polycystic ovarian morphology, instead of doing a TVUS at that level. Okay, and like any other test, there are limitations to the use of this test, and there are things that can increase or reduce the levels. So keep those in mind. Systemic inflammatory conditions, pregnancy, parity can affect your levels by increasing or reducing them, as you can see. So perhaps we will eventually agree on a value of PCOS diagnosis as well, of about 5.4, or an age-based threshold. And what this current study says is you can still use it as a cutoff, but basically based on age, BMI, standardization of the assay and all that. So at the moment, it's not yet standardly recommended to be used for the diagnosis of PCOS. So please don't start doing it on every of your patient with PCOS. Only at that diagnostic algorithm place where you are supposed to do TVUS, you would do otherwise. That's the place that you would now do the polycystic ovarian, the AMH levels. How about adolescents? Now, when they looked at adolescents, they actually found that the cutoff values for the AMH were much higher, going all the way, like you can see on this particular column, that they went all the way up to 14 even. So the cutoffs are much higher, and at this point in time, it is not recommended to be used for adolescent diagnosis of polycystic ovarian morphology. And in adolescents, like I said, ultrasound as well is not the best criteria anyway. So you would rely more on your clinical features of hyperandrogenism and oligoanovulation based on the time from menarche. It is not fixed in adolescents, it's based on the years from the onset of menarche. And so that's what you would use. Now, coming towards the end of the diagnostic aspects. So when we look at the international evidence from a very recent guideline that I mentioned, the 2023 guideline, and I'd recommend all of us to just go through. It's an amazingly summarized guideline. So what they say is this, right? That the serum AMH could be used for defining polycystic ovarian morphology in adults, not in adolescents. However, serum AMH should only be used in accordance with the diagnostic algorithm, as I've talked to you about, noting that in patients with irregular menses and hyperandrogenism, an AMH level is not necessary for PCOS diagnosis. Please, let's keep that in mind. And when we then expand further, we say that AMH should not be used as a single marker for the diagnosis of PCOS, okay? But AMH again cannot yet be recommended to be used in adolescents, and either AMH or ultrasound may be used for your diagnosis of polycystic ovarian morphology. Do not use both tests because that's now classified as overdiagnosis, right? And labs involved in AMH should actually use population and assay specific cutoffs. And so basically serum AMH is now recommended to be used as a defining PCOM with the cutoffs that have been suggested as part of the overall diagnosis, okay? So just touching on one slide with treatment. Treatment is, if I have to talk about treatment, it's a very, very long topic, but I'll just summarize on this one slide. So the treatment of PCOS is dependent on now the different characteristics of PCOS. So if you are looking at oligoanovulation, then in these patients, if they are not seeking fertility, you can use your contraceptive pills. The combined oral contraceptive pills with the low dose estradiol is what is recommended, and or only progesterone only pills. I'll not go into the depth of that. You could also use metformin in patients who are overweight or obese. With BMI more than 25, you could add or use alone metformin, especially if there are contraindications to your oral contraceptive pills. If you are seeking fertility, then the step one or the option number one remains letrozole, where and when applicable, but by this time please have referred your patient to an endocrinologist and or a gynecologist, okay, to help with fertility treatment. Gonadotropin releasing hormone agonists also have a role, and if nothing else works, then also IVF is an option for fertility treatment. If your patient has dysglycemia, for diabetes, I request you at least do a fasting blood sugar, not a fasting insulin. Insulin measurement is not even recommended in diagnosing PCOS, which a lot of people like to do. It's a cost that doesn't help much. Okay, if your insulin is elevated, does not mean necessarily that, okay, well, it does probably imply insulin resistance, but if it is not elevated, doesn't mean you don't have insulin resistance, right? So let's avoid using insulin measurements. Do a fasting glucose at least, do a lipid profile where applicable, okay? So then if you look at the other aspects of treatment is hirsutism. Hirsutism, if you're on contraceptive pills, that can help a lot, but also you could use local methods like I talked about epilation and shaving and laser therapy and all that. And if that doesn't work, you could use eflornithine, which is not commonly used in our setups. Same with acne. Now here you will need to engage your dermatology colleagues to also help with the management. So you can see it's a multidisciplinary effort. For weight management, please engage your nutritionists, your dietitians to help you with managing weight. Make sure a counselor is on board because it is a distressful condition, as you can see. We cannot deny it, but it is controllable, it is supportable, right? So let's support with a multidisciplinary based approach. And this I already showed you the whole spectrum of specialists that the patients with PCOS need to go to, requiring a multidisciplinary team approach. So, in conclusion then, if we look at the simplified pathway to diagnose PCOS, then first thing, a good history. Take a history of oligoamenorrhea, take a history of clinical hyperandrogenism. If you have ruled that out or that's not the case, then you think about doing an AMH level. Now, if you have got only one of the two, you do an AMH, use a cutoff of 3.2 for diagnosis of polycystic ovarian morphology, along with all the other tests as recommended. And then you decide on the specific management based on the specific morphology, based on the, all the conditions that the patient has in the spectrum of the polycystic ovarian syndrome, and refer the patient accordingly. And again, use standardized assays for assessment of polycystic ovarian morphology for AMH assessment. And AMH, other than PCOS, has a lot of uses, as Dr. Ingrid and other gynae colleagues will tell us. It has its use in fertility treatment. It has a use in menopause. It has a use in evaluation for premature ovarian insufficiency, even cancer treatment before giving chemotherapy levels, okay? And as I said, the cutoff of 3.2 is used. Exclude other causes before you diagnose PCOS and manage using a multidisciplinary team approach. Make sure you are taking care of the metabolic, hormonal, reproductive, anthropometric, psychological, and sleep components together, okay? And there is no special diet or no special exercise, honestly, that has been shown in large studies to be specific for PCOS. You know, some patients are told by people out there, I'll just say people, I'll not say which people, but they are told, you know, use this diet, this is a PCOS diet, please. There's nothing specific. They should see a dietitian to be helped with the correct diet as in keeping with the population-based recommendations, guidelines that we have. So I'll actually end by saying this. How well do we support our women living with PCOS? Or amongst us, I'm very sure if it's 1 in 10, there are a lot of us who are suffering or who are actually going through living with this condition, yeah? And we shouldn't be suffering from it. We should seek help from the right places, from the right sources, and direct our patients to the right sources. So let's not make it like a stigmatizing conditions, a judgmental situation, like we'll hear a lot of these words in obesity management as well, but also in PCOS, it's not, you're not supposed to be judging, you're supposed to be supporting, understanding and supporting. And these are support groups available. You can lead your patients to them. There's PCOS Awareness Association. It's a global association. And I was pleasantly surprised to find out that we have a PCOS Foundation of Kenya with more than 1,000 members. And your patients can get a lot of support when they join. And let us as specialists, as endocrinologists, as physicians be joining out in these spaces to be able to support our women living with polycystic ovarian syndrome. Thank you.
Thank you, Saira, for that insightful talk.